Hello, this is Ian, the producer. The audio on this month's episode of Psychiatry Unbound is less than perfect, sadly. We've decided to release the episode anyway, but if you find you need to refer to the transcript of the episode, go to psychiatryonline.org/psychiatry-unbound.
Hi, I'm Dr. Laura Roberts, Editor-in-Chief for the Books Portfolio of the American Psychiatric Association, and welcome to the APA Books Podcast. Well, hey everybody, welcome back to Unbound. Today we are covering the topic of refugee mental health and expertise in supporting the well-being and health of refugees. Our guest is David Kinsey, who honestly is one of my most favorite people ever. And he's a hoot, but it's a sober subject. So we'll see. We'll see if we get kind of the playful side of Dave come out. I'm not sure. But the book that he co-edited is called The Psychological Evaluation and Treatment of Refugees. And this was a book he did with George Keepers, another one of my favorite people. David and George are at the Oregon Health and Sciences University in the Department of Psychiatry. And Dave, who's with us today, received his degree a long time ago. I won't say when, at University of Washington, and then completed his psychiatry residency there, and also did a fellowship in transcultural psychiatry at University of Hawaii, which was really interesting. And so you were ahead of things, Dave, with your training and the emphasis of your work. Your interests really focus on hospital psychiatry, psychiatric treatment of refugees, post-traumatic stress disorder, and mood disorders. And I want to thank you. I want to thank you for being you, first of all. I want to thank you for taking on this book with George on refugee mental health. You know, I was aware of your clinic, and I would love to know, and I'm sure the listeners would really be interested in the history of this clinic. And it's really out of that the book derived. But there are so many unique things about this book that are so valuable to the field. I just really want to thank you. So let me just ask you, why did you think the world needed this book? What was the hope that you had in developing this book for us?
May I tell you a little bit about the history of why we got into this? Because that explains a lot.
Yeah.
During the Vietnamese War, I was a doctor in Vietnam, a civilian doctor as a conscientious objector. And I really got upset with what Americans did and what happened there. Later, I worked for a year with the Aborigines in Kuala Lumpur in Malaysia, and then I came back into residency. After the fall of Saigon, I think about 1976, we started getting a lot of refugees, and I had guilt about America's role, and I thought we ought to be doing something for these people. So we started the program because we had a lot of refugees in Oregon. It took a lot of people. And there was another program offering kind of psychological services. My Vietnamese themselves, that program collapsed and we joined with it and had our program. And from the beginning, we did something unique. We had full-time Asian Vietnamese counselors in our program who was interpreters and case managers. They were hired by the university, and we didn't have outside interpreters. This took a lot of training. They were picked because they were good people you'd go to just to talk to. They didn't know much about medicine or psychiatric disorders. We gave them that experience. But over the time, it developed that this was the right model. No one else uses it, but it's the right model. And so we were very happy with it. At the end, we had a lot of, it was interesting. We started out thinking it would be Vietnamese and then maybe other Cambodia, then Laos. And then we thought, well, we train them, they will get settled and it would be over. We'd be back and do something else. But the refugee crisis never ended. we've seen it just expand and expand. Guatemala, Bosnia, Somalia, to Iraq, Iran, and it just keeps going on. And the refugees coming to the United States is varied up and down, but it still is a big number. And each time we got another group, we developed another program with people from that culture being our confidant. Why I thought the book was important is it's written by psychiatrists for psychiatry. And we are very interested in helping other people understand both the problems and the needs to work with refugees. For psychiatrists, it's a huge problem. And even besides that, cross-cultural issues are very big in American medicine. So with our experience and I guess that narcissism and need to tell other people, we wrote this book. And there's a lot of books out about PTSD and trauma. None that focus on refugees, which are focused on the treatment, the training and treatment of refugees. And so we had this book with a lot of experts, some from around the world, most of them from our own program.
Yeah, thanks for that background. I mean, it naturally occurs to me from my own work, but from my colleagues' work as well, that there's a real challenge around secondary trauma. I mean, when you learn about this inhumanity toward one's colleague and friend and fellow human, it seems like you had already witnessed a lot of that in your own life. So when you came to the clinic, you'd kind of crossed that river, if I can put it that way. But do you have reflections on, how you would advise psychiatrists or psychiatrists in training who are thinking about undertaking this work, but where it might be so different from their own personal life experience, and how to protect themselves and think about that experience as they approach it? I think people are scared. They're scared to take on that work. It's hard.
It's
work.
very hard, and you see the worst of human beings. You see the effects of massive, massive torture and trauma, and relatives killed, starvation, rape, and you hear about it. The first group that really hit us hard was in Cambodia, the whole haunting time. And at that time, actually, there was no PTSD diagnosis, which came in 1980. And we didn't quite have a handle on what was happening. And frankly, we didn't quite believe it at first because it was so traumatic. It was so awful. And even though I read about the Holocaust and other things, this was really out of our experience. You're right. I had seen a lot of trauma in Vietnam and some in Malaysia. I wasn't prepared for this amount. We stuck with it. I limited my new patients to about 2 a week. I couldn't handle more than that. It was just overwhelming. And then you start getting, technically kind of countertransference or empathy strain at that point. And that happened. And I hung in there with it. The patients got better, not cured, but better. And I got better at doing it and could separate myself a little easier. I think I should say I've seen the worst in psychiatrists doing this. Give a PTSD scale, get a depression scale, say they have it, give them a medicine, tell them they're on the way. That absolutely isn't. I think you're right. It means they're scared. And they're scared to take a history. They're scared to listen to the story. And they're scared of their own reaction. And you keep patients at a distance so you don't have to deal with it. But it's wrong. If you want to help people, you listen to their stories. And it takes a long time. It takes an hour and a half to do the first interview. And it's done with an interpreter who has their own problems. They're often going through the same thing themselves that they're listening to. It took about 3 years, I think, to get good counselors to do the job well and not be traumatized themselves. And so I guess I'm saying that we have some very, very good ones who stayed with it and are doing a very good job. But it is hard.
Yeah, I really appreciate what you're saying very sincerely. And I wonder if there's something special about your department that this has been able to develop. And, I think a lot of places have clinics, but they don't make such a sustained commitment to a vulnerable population like this. It's either not financially advantageous, or it's not so clearly tied to their mission, or there are different fads that come and go. Oh, we'll do this, we'll do that. But I'm so impressed with how decades of work in committing, as you say, to more and different, but also the original refugee populations. So what about your milieu has allowed that to continue there?
Yeah, there are a couple of people really important. The new chairman who brought me there was Jim Shore. He worked with McCall, the North American Indian tribe. He and I did some studies with them and consulted them. And he had a dedication and he worked in Indian health service. He had a dedication for cross-cultural things, as did the next chairman, Joe Bloom, who worked in Alaska. And was very interested in cross-culture. He works with cross-cultural murderers. He has a strange fascination. But they were dedicated to keeping this program going, and gave us a cross-cultural and accurate refugee focus. And you couldn't do it without a chairman dedicated to it. And those two people have greatly helped us. Now, I should say, our current one, George Keepers, actually had a clinic for Koreans himself. So he is very supportive.
Yeah, and helped you with this book. That's
yes,
great.
a lot.
Yeah, it's wonderful. So, do you have some particular stories? I mean, with this particular book, people might even be overwhelmed at the thought of even opening the first page. So how would you invite people into reading this book? And what are some of the stories that you hope people will read and be influenced and changed by?
I'm not sure those two questions are compatible. The stories I want to tell.
The stories are hard.
Yeah, they're hard, and I'm not sure people would be interested. I mean, they're interested, but I'm not sure. But let me try. Let me tell a couple of stories, which I think give a flavor of an easy way at first what we're dealing with. Had a Vietnamese woman, of course, was a Vietnamese consular who never got well. Always had backaches, headaches, always complained about her husband being killed, and nothing worked. It was all the same. And then one session, the consular got called out of the room, and she switched over to pretty fair English, put up her skirt, and showed this terribly deformed leg. Her husband had abused her and thrown boiling water on her leg. It had this terrible scar. She was glad he was killed. She was relieved he was killed. She could not tell another Vietnamese woman that she was happy he was killed. An American doctor is safe. He's not going to make any judgments about it. And she seemed greatly relieved to tell the story. The Vietnamese consul came back in the room, and she switched over to Vietnamese. Headache, backache, can't sleep. I talked to her, and I talked to her a bit. Said, we're going to have to talk with the consulate about this. I'm sure she'll be supportive. But it did take about 4 or 5 sessions before she could say it with the consulate in the room. Things are not like they seem. And there are more complications. That's why you do it for a long time. That's why you have people help you.
About this one study I did with one of my mentees, where we looked at stigmatizing health conditions. And so the question is, who would you talk to about a stigmatizing health condition? When it's stigmatizing, you want to talk to somebody who is as distant and different as possible. And if it's something that's not stigmatizing, either routine or just meaningful and not stigmatizing, you want to talk to somebody who's as similar as you are in terms of your clinician. Isn't that interesting how stigma splits it about the kind of clinician you want to be talking with? Yeah.
That is really the truth. I'll give you another example. We had a woman from Africa, actually very prominent woman. She worked in the parliament. The village came in and shot her husband. right in front of her. And she went through a lot of trauma with our counselor who's speaking Swahili. And then she asked the counselor to leave. And then she said in pretty good English, that isn't all what happened. I was gang raped with my dead husband there. And I feel so guilty and so dirty. And I just listened. I gave her a big hug. We went back to ordinary stuff and never talked about it again. But I think that was one of the most important things in life to know, that you tell me that I accepted it.
Yeah. And just stood with somebody and didn't react negatively. Yeah. Yeah. It's amazing. So you must have developed special ways of working with these counselors who came from the same origin as some of the patients. What were some of the approaches? And it sounds like some of it was learning by doing, said with love. I mean, here we are, always learning by doing. But what were some of the things that you all adopted as practices in the clinic?
Well, I think we had a group meeting every week with the counselors, especially when we started. And each of them told some of their work and their stories. And it was a fun meeting. It was meant to reduce the stress. And that was helpful. We often, after some sessions were hard, the counselor and I would debrief it and talk about what we learned and how hard it was. Some couldn't do it. We had a Cambodian counselor who was learning, sitting in with us. And in the middle of the interview, he would pick up a Time magazine and started reading as the patient was telling this terrible story. Afterward, I was furious with him. How could he be so callous? His parents had been killed in Pol Pot the same way that the patient was. I really felt for him. He had to work that through for several years before he could kind of handle it. But he actually ended up working in another clinic.
So another thought I have is that psychiatrists in everyday practice are encountering the clinical needs of people who happen to be refugees. And so it's one thing to build a clinic that's really tailored and has this special team and all that. But do you have any advice that you would just offer to, I can just call it everyday psychiatrist, in an everyday clinic, about
I do have some advice. I don't know if it's very good, but I remember taking anthropology and you're supposed to respect people from other cultures. That's not enough. You have to like people from other cultures, enjoy their culture and accept it, and actually show no anger or upset about it, but engage in it. And I think some doctors in internal medicine have done really good at this. We had a very good doctor who worked with us this time, sharing patients. Did very well. And they just enjoyed it. And the other thing is not to be in a hurry. And I know managed care, you got 10 minutes or 15 minutes. You have to be very careful. You can do very much in that time, but that's what you work with. But in general, you slow everything down. Take a lot of time. Not being patient. And you never would, tell me the chief complaint. Just come on. You can't do it. That won't do it. It's too scary. They don't know the chief complaint. They know they got a headache and a back. You can't sleep. So it takes a different mindset. And I find myself just slowing down and just taking a lot of time. There's a lot of nonverbal communication. You get used to, and also you give. And they're picking that. They are extremely sensitive to rejection. They've been rejected half their life. And it takes a little bit of let them know it's not safe.
Yeah. So I for the listeners, I need to say that Dave is emphasizing how even just a little subtle cue about rejection or a negative response to something that's either been said or something that's been demonstrated will really turn away the patient, and how sensitive they are to that. And anyways, and Dave made a funny face, so I'm just trying to paint a picture for our listeners.
Don't do that.
All right, exactly.
I'd like to tell a couple other stories.
Yeah.
This man was very angry. He was Somali. He screamed at people who came by his apartment. He had no friends. He was isolated. He made several visits, appointments to the clinic, but he never came. He finally came and said, first thing, I'm not going to talk about it. He sat down and listened. I told you I'm not going to talk about it. And then he cried and cried and cried. And I did too. That's very sad. The rebels came into his village, lined up the men, and started shooting them. And just as they got to him, his oldest son stepped in front and took the bullet. The bullet went into him. It looked like he was dead, but he lived. But the son didn't. And the guilt and shame, he lived with it. It's hard to know what to say, but I think I said he must have had a very good father to be so brave. We didn't talk about it anymore. I saw him a few more times. The change was dramatic.
So I just want to say that Dave and I are both crying now.
Yeah.
I mean, to hear stories like that is so hard. And it is remarkable that just that letting go of one story would do it. Now, so that shift in him, let's take 1 minute with that. Why? He must have done a lot of work when he would make appointments and not show, make appointments, not show. And then he finally came, said he wasn't going to say, and then he did say, and then he shifted. I mean, do you want to comment on that arc?
Yeah, I think it was bursting up inside of him with so much pain and shame. And when he finally could talk about it and let it out, it was painful for me to hear and painful for him to tell it. But it just eased. He kept on coming. We saw him probably 4 or 5 times more. It talked about normal things, how you live in the United States, how you start a party, how you get friends.
Yeah, it's so interesting. And I know you have another story to tell, but I just want to cross over. I'm the editor of a journal, and we just did a call for trainees to describe a moment in a very brief essay about something that was transformational or momentous on their journey as becoming clinicians, physicians. And oh my God, we got hundreds. And I have to tell you, Dave, I sit there with my Kleenex box and I just read these stories and I read them. But I have to tell you, they're so powerful. I feel light as air for days after reading these stories, because even though some individual story could be painful or whatever, but there's something about storytelling that is so beautiful and connects us, even when the content itself is hard, right? Mm-hmm. But that, anyways, it connected me. It connects, this week I'm feeling how deeply it connects me with my joy in being a physician, and as I'm hearing you, it's of course terrible to hear about this man, but I'm so grateful that you said what you did to him. Do you know?
I think one of the lost arts in medicine is listening to stories and listening to our patients tell their stories and sharing their lives with us. I think that is one advantage that psychiatrists have. We're trained to do that. I had another story. Okay. This is a Bosnian man, a very, very good man. He was a leader in the community. He came and worked he was a welder, and he gave lessons in the mosque for young people. He massive traumas. He ran away as the Bosnians were chasing him, as Serbs were chasing him. He went into his in-laws' house. He told them they got to go with him, and they didn't. And they were killed the next day, which he always felt guilty about. He was captured. He was a prisoner of war camp for a long time. He said at that time, one of the worst things he saw was the guards gave one of the prisoners a piece of bread, and that prisoner didn't share it with his own son. So that was terrible. So eventually we got to what was the worst thing you saw? The Serbs had went into a village, killed the people, and his job as a prisoner was to clean up the mess, take out all the furniture, take out the bodies. And in this group of bodies came a little girl, about 3 years old, holding her hand and crying. He picked up this little girl. I'm sorry. I'm very sorry. He picked up this little girl and went to the guard and said, "What should we do?" And the guard grabbed the little girl, threw her against the tree and killed her. That was the worst thing I ever saw. Incidentally, he had probably, we figured out, a little girl who was blind in his Korean class. And he had to stop because he think that brought back memories. He kept coming, and he was a very good patient. I mean, a very good person.
Well, I guess I need to thank you for doing this hard work for all of us in psychiatry. And I'm sure you saw people get better and some people not get better. But I'm really grateful to you. And I'm grateful that you took on this book and sharing this experience that you've had with the clinic. And I'll just emphasize about storytelling. You know, you can be pretty hardcore biological psychiatrist where, you know, you don't have a lot of time. But how long did it take you to tell just a few stories that carry so much humanity in them, right? It doesn't take a lot of time. Sometimes it takes a lot of time. And sitting to build that relationship can take a lot of time. But finding a way to introduce enough space for someone to tell you a story of significance about their life, I don't think takes that much time, right?
It takes a good relationship.
Yeah, well, that's true.
Yeah.
To get to the right story, right? Yeah. Good. Well, thank you for doing this beautiful, hard work. And thank you for doing this book with us. And I think you've conveyed things in a way where people who might not have picked up the book may pick up the book, not be quite as frightened by it. And are there other things you'd like to share with us about the field?
I'd like to share a couple lighter things.
Yeah.
I worked in Malaysia as a psychiatrist after I finished residency, and I could speak a fair Malay at that time. And we had a Malay couple coming in, and I was talking to them in Malay and giving it, going my old slow way, but getting it, and about main problems, symptoms, sleep patterns. And in about 5 minutes, the husband looked at me and said, "You know, we do speak English." Oh, we both laughed. Everybody laughed. But it was really a stereotype I had of them. You know, a Malay couple, they don't speak English, but they were very well. At least they gave me a break. One more study I'll tell about this. I saw a couple and the husband was very paranoid. His wife was having an affair, and she's trying to say, and we talked. I had a medical student with me, and we started him on some antipsychotic medicine. We've seen him in the room. Saw them about 2 weeks later with the medical student. Everything was better. The husband, the wife liked him. There was no more paranoia and no more threats or anger. And so I turned to the medical student and said, "Sometimes these medicines work pretty fast." He interrupted, "But doctor, I didn't take your medicine." I told him, "Shut up, I'm making a point here." I didn't say that, but that was what was on my mind.
Well, so what made the patient better?
I think the relationship we had in the first meeting,
Yeah.
we were talking about it and kind of saying, "You know, I don't think what you're thinking about your wife is true." He said, "It's not true. I believe her." I think maybe you're overreacting. I think, and maybe they started talking. You know,
Mm-hmm.
but sometimes we give a lot more credit to the medicine than
That's great. Well, Dave, thank you so much for visiting with us on Unbound. Thanks for doing this wonderful book. Thanks for all the work for so many years in this very hard but important area. And I hope people, whether they have a large clinic with people who are of refugee status, or if they just encounter people who have just really different backgrounds, that they'll follow the guidance you have about listening, slow it down, be mindful of your own body language and any reaction you have. And I liked what you said about don't just accept and respect other cultures, but embrace it. See what you might enjoy and find joy in the difference, right?
Psychiatry Unbound is hosted by Dr. Laura Roberts and produced by Ian Martin. Our original music is by Willow Roberts, and our executive producer is Tim Marney. This podcast is made possible by the generous support of Stanford University. We are a production of American Psychiatric Association Publishing. Be sure to visit psychiatryonline.org/podcast to join the conversation, access show notes and a transcript, and discover new content. Or subscribe to us on your favourite podcast platform. Thank you for listening.